The first person I want to introduce is Professor Clara Chow. Clara is a cardiologist and a professor of medicine at the University of Sydney, also academic director at the Westmead Applied Research Centre, and also academic co-director of the Charles Perkins Centre. And Clara, I know just from Twitter stalking you that you received your AM this year, and so did your dad in the same year. So that's pretty cool. I'd love to hear more about that, but over to you for your presentation first.
Well, thank you very much for the lovely introduction, and thank you very much for the opportunity to present, as well as the nomination to come here today, and tags Cheryl Jones in the audience for that. Thank you. I don't know how my father and I got honours in the same year. Yeah, but we can chat. Not exactly sure how that happened. All right, well, I was asked to talk about whatever I felt like, which was an interesting opening. So I get to talk about something I'm really passionate about, and that is cardiovascular disease prevention and care. So I probably don't need to remind you that heart disease is the leading cause of death in Australia, and it's disproportionately higher in rural and regional areas, as well as Aboriginal and Torres Strait Islander people in Australia. Cardiovascular disease is costly, costing about $12 billion a year, and that's just in direct health costs. And that's about 10% of the Australian health expenditure. And unfortunately, prevention is poor. And an example just there is, a recent analysis of electronic medical record data from Australian general practices, identifying that over 60% of adults with coronary heart disease aren't on basic secondary prevention medicines. So look, as a cardiologist, it's been, amazing to see the progress and the technology that has taken, I suppose, the heart attack from being a condition that was associated with death 50 years ago to one that people survive from. But I think that as a cardiologist and a researcher, I must say we have not been good at implementing prevention and providing access to care at scale, or providing them to everyone. So this is why I think it's important to innovate to reduce the burden of cardiovascular disease. So I've been both proud and happy to be able to contribute to the research that have highlighted the gaps in cardiovascular disease prevention. Yes, that was me through my PhD studies. But this research work has shown the commonness, I think, of gaps in prevention across the world, particularly in low and middle income countries. And this paper identified the large gap in both awareness and control of high blood pressure, and the large gap in secondary prevention of cardiovascular disease, which is particularly large in low income countries. And alongside this research, I had the opportunity during my postdoc to develop a tool called the Environmental Profile and Community Health Instrument, where we were able to collect information from communities about the factors or the context by which people could access cardiovascular care. And from that, we were able to, publish and describe a number of papers looking at the availability and affordability of cardiovascular medicines, blood pressure medicines, diabetes medicines, as well as the availability and affordability of fruits and vegetables that are all incredibly important to being able to do cardiovascular disease prevention. And with collaborators and students, I've also had the opportunity to, I suppose, raise awareness around the inequities we see even here in a high-income country like Australia, the socioeconomic disparities in the management of coronary heart disease, as well as the gender level disparities in the management of coronary disease. So fundamentally, gaps arise from incomplete implementation of new treatments and services. And I suppose as a scientist, and I suppose I ask you or as scientists, what is our responsibility in implementation of the science or the evidence we create? And I say that to myself multiple times. What is my responsibility in implementing the research that we have created? And I suppose in this week where it's very important that we think about equity in health, I must ask us all to think about what is our responsibility in talking about Aboriginal and Torres Strait Islander health and addressing that equity when such an important decision is about to be made in Australia. So the other sort of part of my research, or the research I get to work in, is in designing and testing new innovative solutions. And at the Westmead Applied Research Centre, our goal is to create innovative solutions using technology to reduce cardiovascular and other chronic diseases. And our core values are innovation, co-design, and value-based care. And, you know, this is, I suppose, just some points along our digital health journey. About half of our program is in digital health. And I recall this started when I returned back to Australia in 2010 and got my first grant from the Heart Foundation for the Text Me randomised trial standing for tobacco, exercise and diet messages, which was a simple secondary prevention trial. Well, it was a simple trial in that, you know, the focus was simple. We were trying to improve secondary prevention amongst people that were with coronary heart disease. And we randomised people to a text message-based support program that was customised and individualised to their preferences and to usual care. And this program demonstrated lower cholesterol, blood pressure, more likely to have good diet, more likely to quit smoking. And this research started I suppose, a cascade of other collaborations and research that I've had the privilege of being able to do with many people, including the person that's going to speak next, funnily enough, which has been great across the course of the last decade. And I suppose flagging up another milestone, in 2017, we won this thing called the Google Impact Challenge. And that sort of started our software journey in developing digital health platforms and enabled us to create the Text Care platform, which last week saw its 100,000th patient go through it. So, you know, exciting what sort of things we've seen along this journey. All right, so I'm going to give a couple of examples of the sort of questions that kind of excite us and we kind of want to address. So this led by a PhD student, newly minted PhD student, Daniel McIntyre, who asked the question, can we turn time waiting for healthcare into productive time that can improve healthcare experience and outcomes? And this was, I suppose, kind of our justification for this being an opportunity. And, you know, this is a complex diagram, but really what we were trying to do in this review is identify all the places we wait in the healthcare system, you know, from that waiting room to waiting for the next appointment, to waiting for the subsequent appointment after that, to waiting for a procedure, to waiting for a test, and try to put it into a bit of a figure and realize how, one, convoluted it was, but also when you added up all the time across all of those different waiting opportunities, there was an opportunity to use that time better. So we started this while you were waiting trial, and our context or problem was the patients with cardiovascular disease in our public health system often spent more time in clinic waiting in the waiting room than with their doctor. So we designed this randomized clinical trial to assess whether waiting time could be used to deliver education on cardiovascular disease risk factors, as well as education on CPR. Now, education on cardiovascular disease risk factors might be about how you improve your own health, but education on CPR is taking that opportunity on whether you could actually improve cardiovascular health for somebody else. So we used a 2-to-1 randomized design because we were keen on understanding the implementation processes. So we wanted to increase the number of people that actually got the intervention. And within the intervention group, we also randomized those patients to whether they got education on CPR or not. So the digital intervention was a curated bunch of educational videos, and we curated this through a multi-stage process involving clinicians, researchers, and consumers, coming to a final list of videos which were queued with top-rated clinician or consumer staff picks able to be queued, but also selection able to be ordered based on participants' interest ratings, and that would auto-queue the videos, and the videos were delivered via RedCap on iPads. So, you know, I suppose in quick, 220 people received the intervention, 110 received no intervention. Overall, 765 videos were watched, an average of 3.5 videos per participant. And in general, participants rated videos highly. The most watched videos was the blood pressure video and actually the CPR video. So you can see from those light blue lines that actually all videos were watched quite well. And perhaps maybe the smoking one was watched a little bit less, but perhaps that's because it was less relevant to some people. So our results were that people were more likely to report high motivation to improve cardiovascular disease lifestyle behaviours at a relative risk of 1.63, more likely to report high clinic satisfaction at a relative risk of 2.19. And the CP intervention participants were more likely to report high confidence to perform CPR at a relative risk of 1.61. And we concluded that the concept was hence feasible and scalable and suggests improved health, and future studies could examine the potential for impact on clinical outcomes. So I'm going to just touch on one other example, and I've chosen this example because it seems to be topical these days, but actually we did start working on this a number of years ago. And this question was, can conversational AI help us follow up patients at scale? And we did this as a test application in patients with AF. So I haven't got the actual recording, but to give you a bit of a feel, the visit was done by IVR. So hello. This is Westmead Hospital calling for Mr. Gary Chan. There are some important parts of your atrial fibrillation care that we want to help with you today. Yes or no, is this Gary? First, we'd like to check how your overall health is. Would you rate it as excellent, very good, fair, or poor? In our last call, we mentioned the importance of seeing a GP. Since your last visit to Westmead Hospital, have you seen or scheduled an appointment with your GP? I hope you get an idea of what this intervention looks like. So in addition to us trying to ask the questions, are there ways to leverage technology to improve post-discharge care, and can we follow up visits at scale helped by conversational AI? We also wanted to ask, can we risk stratify individuals in these conversations? So the overall program looked like this. We had 7 automated follow-up visits, and they were conducted across 6 months. And the initial centerpin of each of those was a voice-based conversational AI visit. And it was supplemented with text messages and websites and other multi-channel communication type information. If they didn't respond to the IVR, they did have an ability to respond to it via text as well. Some of the themes that we looked at, we had either querying items or educational and support items, and the querying items were things like asking whether they had been to their GP, asking if they had barriers to transport, asking about their overall health, asking about their AF symptoms, their medication confidence, and their adherence. And based on that information, they would get risk stratified, and if they fell into certain high risk categories, they would get a real visit from a health practitioner. And the self-management type information is also listed there. So look, we have actually completed this, but I can't share the full results, but I'll give you a little bit of an idea, because, you know, when I started this, I wasn't sure if patients would take to it or not. I was really uncertain. I mean, you know, will they interact with an automated voice? And I think that, you know, we're pleased to see that, you know, 76% of them did engage with the automated voice on the first appointment, and you can see that drifts down over time. But amongst the people that did engage with the voice-based visit, and this is fully engaged, as in completed the visit, the satisfaction rates were very high. And I suppose we feel that we can conclude, or at least think from this, that this has potential. We also have done a detailed qualitative evaluation, which I can't do any justice to again today, but I suppose just a few comments here that people found that the interaction with a voice-based AI was convenient. They found the interactions engaging. They could do it when they wanted to, when the voice rung, or they could ring back. They found the information novel regarding their health. They trusted the source because they thought it was reputable. They were more engaged if it was more tailored to their health, and they were, though they were overwhelmed by some of the large amounts of information, but they felt that it helped by providing it in bite-sized chunks afterwards. They found that it was flexible with the multi-channel delivery, and they liked the continuity of support that we're able to provide with this, as well as some of the reminders. So I'll end there, given I think that I've got 10 minutes. But I want to say this is what I mean by frugal innovation in cardiovascular disease prevention and care. Frugal innovation that is creating smart, low cost and effective solutions to big problems, of which I think our big problem is large evidence practice gap in the implementation of proven preventative treatments for cardiovascular disease. Thank you.
Just wanted to ask you something which may be a little bit challenging, but when I was speaking to one of our mentees, Francine Mark, yesterday, she told me how they gave a 2-week trial of high fiber diet and it reduced hypertension, but it was a bit much to get everyone to have every day. I don't know if she's here in the audience, but that seems like a fairly cheap strategy to be able to introduce, to implement widely around the world without an expensive drug. So that seems like, I mean, sort of up your alley. So I thought I'd see what you thought of that.
I'm all for finding cheap strategies that might be helpful and low cost, and would be happy to chat. I think that you know, the diet one is complex in access sometimes, and high fiber diets are obviously a great concept. The question, of course, is whether 2 weeks is enough. And I think a big challenge in the prevention space, and I think we all know this, is that behaviour change needs to be continually supported, and preventative care also needs to be continually supportive. And a lot of the time we also think about how people will be able to maintain these into the future. And a lot of our focus now is also how we maintain people to connect to their self-management, you know, into the future. But thanks. And yes, you're a bit of a I was a bit nervous presenting to this audience, so thanks. I'm glad you're interested.
Thanks for your presentation, Danielle Matza from Monash. My question is around managing comorbidity, and these AI tools are great and very promising, but how will they manage comorbidity in a patient and the raft of preventive care guidelines that need implementation?
Yep. So, I mean, absolutely. The majority of our patients have comorbidities, and I suppose comorbidities are very broad as well. But we are keen on integrating information on multi-counts, and that's why we're so keen on collaborating with different groups. I mean, a lot of the there's a lot of commonalities across a lot of chronic health conditions, but often when we start in designing a program, we bring a whole lot of people into the room, all of the key stakeholders, obviously including the consumers, but also all of the people that have got different knowledge of those different chronic health conditions, and we start asking them to prioritize, which is hard. And why we ask them to prioritize, though, is that we can't dump all of this information on the patient all at once. But, you know, it's an interesting exercise, I must say, trying to work through how we, you know, prioritize information to support all of their chronic health conditions and comorbidities.